Hello, everyone. Welcome to today's Explore MedTech Innovation Seminar presented by the MedTech Talent Accelerator and the seminar series in Biological and Biomedical Engineering at McGill University. My name is Jesse Ehrlich. I am a program officer in Biomedical Engineering at McGill, and I'm also the McGill Program Manager for the MedTech Talent Accelerator. As many of you know, the MedTech Talent Accelerator is a national training program to launch the next generation of industry-ready talent for the Canadian medical technology sector. This program is a collaboration between McGill, Toronto Metropolitan University, Dalhousie, University of Calgary, Biomedical Zone, and MedTech Canada. So today I'm very pleased to welcome our guest speaker, Dr. Eddie Lang, who is a professor and the department head of emergency medicine at the Cummings School of Medicine at University of Calgary, and for the Calgary zone of Alberta Health Services. Today, Dr. Lang will present a seminar entitled Emergency Department Operations as the Canary in the Healthcare System, Coalmine. So today is a special seminar. As I mentioned, it's part of the McGill course in seminars in biological and biomedical engineering, but it's also part of the MedTech Talent Accelerator Hackathon, which is currently ongoing. It's a virtual event that brings together universities across the country to address an industry proposed challenge. And this year's challenge is improving throughput of hospital emergency departments. So Dr. Lang, hopefully your seminar can provide some perspective and encouragement to our students who are hacking to solve that problem. Eddie Lang is a professor of emergency medicine and the academic and clinical department head at the Cummings School of Medicine, University of Calgary and Alberta Health Services. He's also the scientific director of the Alberta Health Services Emergency Strategic Clinical Network. He completed his residency training in family medicine and emergency medicine at McGill. He is a member of the GRADE working group and has provided methodological support for a number of guideline groups, including the International Liaison Committee on Resuscitation, the WHO and the Help in Kids Research Group on Vaccines. His areas of interest of research include knowledge translation, evidence-based medicine, and health services research. And finally, before we get started, I'd like to do a land acknowledgement. So McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabeg nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. And without further ado, Dr. Lang, please take it away.
Great. Well, thank you, Jesse, for that very kind introduction. It's a real pleasure to be here. I don't often get the opportunity to speak to biomedical engineering students, but I am very excited to do so. I just will add one. Oh.
Everything okay?
So this has been known to happen. Can you hear me now?
Yes.
Yeah, I often experience some IT issues when I share, but Jesse, do you want to put the slides up maybe and we'll walk through them?
Sure. Do you want to give it one more shot while I pull up the slide?
Yeah, I'll give it one more shot. Absolutely. Okay, can you see them now?
Yes.
Maybe the risky part is when I go to full screen.
Okay.
So maybe just by increasing the size and
if you go to slideshow and present.
Okay, we seems to be pretty stable.
Perfect.
Okay, great. So a real treat to be here. One thing that Jesse did not mention in my intro is that I am a McGill alumni. I did medical school and my undergrad at McGill class. I was medical school class of 90. And I was also on the McGill swim team for several years. I was the captain in 1986. I met my wife there in 1986. Many of you were not even a concept at that time. And I still remain very active with McGill alumni activities. And so I'm thrilled to have this opportunity to present. I'm just going to, not knowing what your awareness and knowledge is of emergency department operations and throughput issues, I want to leave lots of time for questions and discussion. I guess I'll start by saying, this is what we want to achieve in the emergency department. This is just the results of a strategic planning exercise that we completed a little over a year ago. And what we do essentially in emergency is we want to provide optimal patient and family-centered emergency care to Southern Albertans. And there's been a number of issues around caregiver burnout, which is why we emphasize provider wellness in our mission. And we want to achieve these goals by investing in education and innovation. We put a strong pillar on access to care, which is really about having the ability to see emergency department patients, and also as well as being efficient with our resources. That's a financial sustainability, and address the issues, as I mentioned before, provider wellness, equity, diversity, and inclusion, and which is also quite important. So I thought I would start by maybe showing you a brief video that I believe will help explain how the emergency department functions. So again, I hope this will work. I'm going to stop sharing that and start sharing a video that I think is very informative when it comes.
Hi, I'm Dr. Mike Evans, and welcome to the Emergency Department, or the ED. So it's a busy place with people of different ages and an incredible mix of injuries and illnesses. So I think the first thing is to step back a bit and consider the physical emergency department is actually interconnected with a much larger web of ED nurses in charge of assessing patients and keeping everything organized from the front lines, to the doctors, on-call experts, works of testing services like labs, radiology, and imaging technicians. All these moving parts work in your favor. Places.
We lost the video there, Eddie. You're muted.
Your local walk-in.
Yeah, sorry about that.
Not a first come, first served place.
Did it work for a little bit?
Who needs medical attention the most urgently? And they do this using a process called triage. It's a French term. So let's start with the French leader that knew something about strategy, Napoleon Bonaparte. Specifically, his surgeon-in-chief, a man named Baron Dominique Jean Larrey. Now, Napoleon liked fighting, or at least having his soldiers fight, and this led to thousands of wounded soldiers needing care at the same time. Traditional army clinics were overwhelmed, and many died as they tried to treat everyone at once. Dr. Larrey realized he needed a system establish triage rules, treating the wounded according to the seriousness of their injuries and urgency of need for medical care. Regression continues in this emergency department. The triage nurse you first saw actually is specially trained to pick up on clues that might make from a more serious cardiac event or appendicitis can make a big difference in your health. Maybe the person being whisked in be filled in purple.
Dr. Lang, it's coming in a little choppy, and the video not so much, the audio here and there. So maybe it's best to share the link, and maybe a little summary would be nice.
Can you still hear us, Eddie? I think we lost him, Jesse.
We did. So sorry, everyone, little technical difficulties. We'll get Dr. Lang back as soon as possible and probably skip the video.
All right, so sincere apologies about the technical difficulties, but is everything back online now, and can you see my slides again?
Yes.
Yes,
Okay.
I can see them
So
clearly now.
thank you to whoever it was that shared the link to the YouTube video. Maybe you can see it in when you're offline. But what I thought I would do next is to ask you in the audience. Clearly, if you've been following the news, and you know many of you are in Quebec, you know the healthcare system is under strain. There's regular media reports of patients waiting long hours to see an emergency physician. There have been some very high-profile bad cases coming out of the Maritimes. So my question to you, and feel free to put it into the chat window, based on your appreciation and understanding, what is the major cause, what is the major contributor to prolonged emergency department waiting times for people who come to emergency either by foot or by ambulance? So think about that, and there's no wrong answers. Just let me know what you think, and maybe someone who's following the chat window can weigh in on how everybody's answering and what they're saying. And then once I have a sense of your responses, I will go ahead and explain a little bit more about what I think is going on. Is that okay, David?
Sounds good. Sounds good to me. We got a few answers already coming in from Asia and Camille. We got a bunch of answers coming in. So go ahead and we can triage those answers after if you want.
Yeah, or just give me a ballpark of what is going on.
We're getting ineffective triage, not enough resources, staff, lack of beds, not enough family doctors, and understaffing, low capacity.
Great answers. Are you back to seeing my slides?
Yes.
All right. So there are two key measures that we use to evaluate emergency department performance. So you can imagine patients walk into the emergency department, they go through an evaluation and a treatment process. Usually about 80% of them don't require a hospital bed. They go home, and the other 20% require a bed upstairs in the wards of the hospital. And what we are reporting to the community, and what is commonly reported on public websites, I'm going to put a really good example in the chat window, is the length of stay for the admitted patients. And this is unfortunately, some very worrisome data that I've recently presented. It's part of our annual report. The 4 lines represent the 4 major hospitals in Calgary. And you can see that in 2022, 2 of them in particular, and the zone as a whole, the whole city as a whole, experienced a marked deterioration in the median length of stay. That means 50% of patients actually waited longer in the emergency department to get their hospital bed than had done in previous years. So we were doing pretty well from 2018 to 2021. Half of our patients got a bed upstairs in under 12 hours. And then things deteriorated significantly in 2022, especially at the South Health Campus and the Peter Lougheed Hospital, where what happened was we experienced something that emergency doctors call nurses call severe bed block. We are unable to see patients in the waiting room because our department is full of the admitted patients who are not able to go upstairs. And I'll elaborate on that in a bit. But first, let me just, as I mentioned, I will put into the chat window a really valuable website. We believe in Alberta in very transparent reporting of health information. And we have a hands-off agency called the Alberta Healthcare Quality Council, I believe. And Health Quality Council of Alberta, they have created this wonderful website called FOCUS, which stands for Fostering Open Conversations That Unleash Solutions. And there you can see a variety of emergency department metrics for the whole province, including the wait times related to what I've just shown you, the time it takes for an admitted patient to get upstairs, as well as some others that I'm going to focus on. So why has this happened, this prolonged waiting time, and what are the complications, what are the consequences? Well, one of the worrisome things that has occurred as a result of this is an increase in the left without being seen proportion. So you see at 2 of the hospitals in Calgary, this is hovering now at 10%, which is just terrible, that 1 out of 10 people coming to the emergency department are so frustrated with the prolonged wait time that they turn around and go home. And I mean, in general, this is a low-risk population. Bad things don't usually happen, but it certainly can happen. And it represents terrible quality of care when 10% of the patients who seek emergency care get up and leave from the waiting room.
Dr. Lang, do you just want to press slideshow and present slides again? That would make it a bit easier to see.
Oh, I am sorry. Oh, I see. But I had a crash last time, but let me try it again. Okay.
Yeah, at risk of crashes.
Okay, is that okay?
Perfect. Thank you.
Right, perfect. So you see the left without being seen has gone up dramatically. Put in the chat window that it's because ED visit volumes, ED visit volumes are am I still there?
We can still hear you, Dr. Lang, but it's a bit choppy.
Is that stick on this?
I think you predicted it. It was just choppy when you went to the presentation mode.
Apologies again. So what I think I'll have to do is just show you the non-slideshow view, if that's okay.
Okay, no problem.
Yeah, I think that's the best way to do it, Eddie, based on what we just saw.
More stable. So one thing to notice, this is the visit volume per year at the 4 hospitals in Calgary. And what I think is telling here is we had a very interesting drop in visit volume in 2020, from usually seeing 318,000 visits across the 4 hospitals the year prior. And of course, this is the beginning of the pandemic. when we saw this roughly 30% drop in ED visit volume, there's a common narrative associated with this, that people stayed away from emergency because they were afraid or because they thought we were overwhelmed. We actually have done some additional research to show that it was maybe that at the beginning, but not all diseases were affected equally. And certain diseases like appendicitis and heart failure and trauma, they rebounded. But all of the diseases related to aerosolized communicable disease infection, so anything related to the common cold or influenza, remained down for 2 full years after the pandemic started. But so that's of interest. But the main point is that the reason that our functioning in the emergency department has deteriorated is not related to visit volumes, because we are still not where we were in 2018 and 2019. So you might think, well, maybe it's because people are sicker that we're in trouble. And this is a graph showing the admission rate. Oh, sorry, no, this is the graph showing the number of patients arriving by ambulance at the 4 hospitals. And you see that this hasn't really changed. If anything, it's gone down in 2022 from 2021. And I'll explain why that is in a minute. But in terms of, this is a kind of a reflection of the severity of the cases. More severe cases come by ambulance, but as a proportion of the total number of emergency department visits arriving by ambulance, this is not changed in 2022, and it would not explain why things have deteriorated in our functioning. By the way, I will get to what is the true cause. Just hang in there. The other thing, okay, so interestingly, in 2022, we opened what was called an integrated operational center, which is a centralized dispatch service which helps direct ambulances. And what we did with that in 2022 is we started sending ambulances to an entity here in Calgary. They have them in Calgary called urgent care centers. They're part of Alberta Health Services. They don't have inpatient beds, but they will see patients who aren't that sick and who may not need to go home. So for example, if you've fallen in a nursing home and you've hit your head and you're neurologically normal, chances are you're going to be okay. We might do a CAT scan to look for any bleeding, but you won't need to come to the hospital. These are the kind of cases that have been directed more and more to urgent care centers in 2022 and have taken the pressure off of the hospital emergency departments. So maybe it's because patients are sicker that things have deteriorated and that we're so bed blocked with admitted patients because the patients upstairs are spending longer. No, that's not the case either. There is no substantial change in the admission rate, which is an important measure of acuity. The red circles represent our big flagship tertiary care academic hospital trauma center. They admit much higher rates of patients coming through the emergency department than the other 3 hospitals. But as you can see, there may have been a trend up at the Foothills, the red hospital, over the last 3 years, or recovering, maybe, influenced by the pandemic, but overall that hasn't changed significantly. It's not because patients are older either. That's a graph showing the percentage of our patients that are over 85 years old. And that has not increased despite the aging of the population, suggesting that we're doing a good job not figuring out other ways of seeing the frail elderly than having them sit for hours in an emergency department. So all this has translated into a prolonged amount of time. This is the 90th percentile for the time it takes from a patient to arrive in triage. That's the first healthcare worker. They're going to meet a triage nurse to the point where they will be seen by an emergency physician. And again, this is not only an inconvenience and a time delay, but this has translated into numerous deaths because patients often present in a way that we would consider undifferentiated, or it's not clear what's going on with them. And as a result, they may be coming in with an abdominal pain. The triage nurse doesn't feel it's that serious. They go back into the waiting room. It turns out that they're actually having a heart attack with atypical, unusual symptoms. And we've had a number of cardiac arrests occurring in the waiting room because patients are not being seen in a timely manner. And that's showing that 10% of the patients who come to the emergency department are waiting longer than 6 or 7 hours to see an emergency physician. It's not a physician staffing problem, and it's not even really a nursing staffing problem, because if the patients who were in our emergency department, and often this is more than 80–90% of all of the beds in the emergency are the admitted patients waiting to go upstairs. If our nurses weren't obligated to be looking after them, we'd have plenty of nurses. So this is how this delay to seeing the first, to seeing a physician has translated into absolute numbers. And this is one of the key measures that is represented on the in the Canadian Institutes of Health Information Know Your System. If you Google CIHI Know Your System, you'll be taken to a website where you can put in your region, your hospital, and you can see the 90th percentile time for an emergency department patient to see a physician. Something else that I'd like to point out, at least in Alberta, is that this is not a problem that is uniform across the board. And let me first clarify, and sorry if I haven't done this earlier, EIP is a really important term for us in Alberta. It stands for emergency inpatient. And what that means is, again, back to this issue of these are patients who have already had their emergency department assessment. We know what's wrong with them. Treatment has been more or less started, but there is no bed to go to upstairs. And what I am illustrating here is that our system is inherently unfair to patients with mental health and addiction problems. You can see across the 4 hospitals, the amount of time, the number of hours that patients are spending in the emergency department waiting for a bed upstairs is much higher for mental health and addiction patients than it is for the non-mental health and addiction patients. And this is terrible. This is patients who are spending sometimes 2–3 days in a cubicle that doesn't have a window with a mental health problem because they don't have a bed upstairs on the inpatient units. And of course, you're not going to get better with your mental health problem if you're in conditions that are ostensibly a violation of the Geneva Convention for the care of for the way you would look after prisoners. So let me get to the bottom line here. The reason we've done this correlation work between the wait time to see an emergency physician, the median wait time is on the x-axis here. The y-axis is the percent of our emergency department beds that are occupied by these EIPs, or the admitted patients. And it's not a crazy strong correlation at 0.58, but it's still nonetheless fairly strong, showing that the more patients we have to keep in the emergency department waiting for their beds upstairs, the less we are able to unload patients from ambulance stretchers, the less we are able to take patients in from the waiting room and evaluate them and start treatment. And so the more we have admitted patients waiting for space, the more we are going to have prolonged wait times. And the ultimate core cause of these high proportion of admitted patients, sometimes in some hospitals, every single bed is an admitted patient. The reason for this is because of hospital occupancy. Hospital occupancy represents the proportion of hospital beds that are occupied, and in Alberta at least, this has been hovering at around 110% over the last several months in many hospitals. That means you have 100, let's say you have 1,000 beds in the hospital, the number of patients inside are actually 1,100. If it's and that will give you 110% occupancy. That means patients are spilling over into unconventional spaces up on the units, be it solariums or family rooms, or they're taking 2-bedded rooms and making them 3-bedded rooms. And here again, the more you have a high hospital occupancy, that backs up into the system and creates delays, an EMS offload delay. And so just to elaborate a little bit more on this, who's in the hospital? Well, of course,
Eddie?
Yes.
We just have one question from a student who has said they have a question about this particular slide. Addy,
Sure.
do you want to ask that question?
Sure. So first, can you hear me, actually?
Yeah.
Okay, great. Yeah, so you said that the challenge right now is there's this problem with regards to getting patients out of the hospital beds. So my question is—
out of the emergency department upstairs is what I've talked about so far.
Okay, right. And so my question is that an issue with regards to being able to better, like, more efficiently diagnose them, or is that more of an issue of essentially, like, these are just really grave conditions and we have no choice but to keep them in the ER a little longer so that we can, better direct them to the hospital beds, or maybe, somewhere else?
So that's a great question, and it's a perfect segue into what I was just about to talk about. Why is the hospital so darn full? And well, for one thing, it's because we have sick people in the emergency department who need to go upstairs, whether they have a stroke or pneumonia or they've broken a hip. And I think I've showed you that really hasn't increased. There's always a steady flow of sick patients who need a hospital bed who go up from the emergency, but that hasn't changed. The other two groups of patients in the hospital are the ones who have completed their care. They are now done their hospital phase of their care, but they need to go to another place other than their home because they are no longer able to manage at home, and they either need a nursing home or a rehab facility. Those patients who are often called alternative level of care patients, and they can make up as many as 15 to 20% of the hospital beds. And of course, when that big a chunk of of beds is taken up by those patients, it pushes the hospital into excess occupancy, creating the backlog of patients in the emergency department, which is also translated to the inability of the paramedics to offload their patients into the emergency department. And then finally, the third category of patients are those that are coming in from home because they have a scheduled surgical procedure. They may have been on a waiting list for several months to have a knee replacement, or maybe to have a gallbladder surgery or a hernia surgery. Those patients are not only continuing to come into the hospital and contribute to the occupancy statistics, but we do have something of a backlog of these cases created by the pandemic, and at least the Alberta government is really pushing to have a catch-up. And the patients, there is despite shutting off these scheduled or elective surgeries for 4 to 6 months when the pandemic just started, we are still bringing these patients in at a very quick pace. So all to say that it's complicated, but the three main reasons is that the three groups of patients that are in the hospital are the sick people coming from the emergency, the scheduled surgical admissions, and then those patients who are waiting to go to a nursing home. Now, when we have an abundance of patients in the emergency, we surge patients upstairs so that we are back into a safe area of operations. Nursing homes don't generally do that. If they know that there are 5, 10 patients waiting for nursing home beds, they generally lock the door and say at 100% capacity, nursing homes are closed. Sorry, we can't take extra. And it's to some degree that inability to surge extra patients that is contributing to the occupancy crisis that we see, at least in Alberta hospitals. And I bet it's the case for multiple Canadian hospitals. Being forced to operate at high occupancy translates into high numbers of admitted patients in the emergency department, which in turn contributes not only to high waiting times for patients who come to the emergency department either by ambulance or by foot, but it even translates into prolonged response times by ambulances, because when things are very busy, we often have 4, 5, 6 ambulance units waiting in the emergency department, unable to offload their patients. And of course, they won't have a timely response to a 911 call if they're trapped in our emergency department hallways, unable to disembark patients. So this is to show that better, but it's just something that has come out in a research project that we have put together, showing the correlation between what happens in the community in terms of the factors that might influence the response to a 911 call versus what is going on in terms of the number of ambulances being activated and the amount of time that the paramedics, the EMS system, has to wait in the hospital to offload their patients, often competing with the patients who are walking in, the inpatient volume of admitted patients in the emergency, and of course, hospital occupancy. So I'll leave it there and open it up for questions. I hope this made sense to you. Happy to provide you with additional resources, but in terms of the key measures, I think if you look at the Focus website that I put in the chat window, you'll see some of the primary measures by which we measure emergency department performance. And you'll notice that on that list includes EMS response time, EMS paramedics staying in the emergency department, as well as hospital occupancy, because they're all intertwined. So high levels of emergency inpatients, high occupancy, and our inability to keep that number at a stable level has lethal consequences for emergency patients. It's really much more serious than about throughput and wait times, although that's often how we measure it. And not only is this bed block problem affecting patient outcomes, but it's really challenging for our providers too. It's really frustrating to go into an emergency department shift. The entire department, or most of the department, has admitted patients who are waiting for beds upstairs, and that leaves us with no space to see the new patients. And we are staring at screens full of names of waiting room patients who might be having something really quite serious, but we're unable to access them, evaluate them, and get tests and treatment started. And we always worry that something bad, and well, we don't need to worry. We know bad things are happening to these patients. But there is a strong effort in Alberta. It's called the Healthcare Action Plan, and it's quite interesting. All of the efforts that the current government has staked their future, if you will, in a way, on resolving some of these key issues. And the Premier, Daniel Smith, has fired the entire board of Alberta Health Services, replaced them with a single individual, Dr. John Cowell, who has the title of the official administrator, and he has declared a laser sharp focus on emergency department wait times and EMS response times, as well as surgical wait times. And he's promised to deliver on these things ahead of the spring election. So time will tell what happens. Just show you, this is our leadership team at the Cummings School of Medicine on a recent retreat. We have Hippocrates in the background. Above all else, don't do any harm. And I want to thank you for your attention and open it up to any questions that you might have.
Excellent. Thank you so much. So we'll open it to questions now. Please feel free to write your questions in the chat or go ahead and raise your hand and ask questions through the microphone directly. So as questions come in, maybe I could start. Dr. Lang, I'm wondering, how do you think we can use technology to solve the problems that you described? And in particular, because you described a lot of insight into the emergency department. So maybe how can technology help us understand these kind of unknown unknowns that might help drive the solutions to the problems that we need?
Yeah, that's a great question. And we're lucky here in Calgary to collaborate closely with the Haskayne School of Business. They have a very strong operational management division that we've done research with. We've collaborated on a number of projects. We've even done some hackathon type activities here as well. I think what would be very valuable is a way to not only diagnose where the bottlenecks are, but to be able to predict when that bottleneck will occur. So as you can see, there's lots of moving parts here. There's there's a relatively predictable pattern of patients arriving to the emergency either by day or by either by foot or by EMS. There is certain seasonal variation that's predictable, of course, with the uptick around the flu season. The time of the day is important. The number of patients who typically require admission. You can often predict these things very, very early on, even before you know a final diagnosis. You can have a sense of whether someone is likely to predict this. So I have yet to see, and we've tried to do this, I think if you had the right data sources, I imagine it would be possible to create something of a dashboard which would alert healthcare systems, hospitals, as to what they can anticipate both over the next hour and over the next 4 to 6 hours. And that might mean, and preparing for a surge of admitted patients upstairs. It could mean that at a critical juncture, the nursing homes do need to unlock their door that has been shut at 100% and take 2 extra patients each, so that we can free up the inpatient capacity to bring the admitted patients upstairs. So I think there's the possibility of doing this. There's an integrated, I mentioned the integrated operational center and how it's being used to send ambulances to urgent cares in Alberta. But there's an integrated operational center which is out of Johns Hopkins University in Baltimore. They're really much more focused on in-hospital activity and the need to cancel surgeries to make room for the admitted emergency patients. But I've yet to see a consolidated system-wide dashboard that can help predict surges in EMS volume, surges in admitted patients, and surges in long-term care patients in hospital that need a bed. So is that helpful, Jesse?
I think so. That's great. So hackathon hackers and biomedical engineers, take note. Okay, so we have a question from Adi. Please go ahead.
Yeah, so actually you answered part of my question regarding the logistics, but the second part of my question would be more like, so if we're looking at ways of reducing occupancy in the ER rooms, from a clinical perspective, is there any sort of focus or any sort of attention that is required to be given to monitoring a patient's not just vital signs, but severity of conditions? And if there's any sort of like tools or technologies that maybe should be developed to better monitor those patients to see if they're worsening or improving, and that will that actually help in terms of maybe, creating a little more efficiency in terms of, which patients are required to be in the ER room and which are not?
Yeah, I don't think that's going to be particularly high yield because, so, if on a typical shift, I'll see, let's say 25 patients, and usually about maybe 5 or 6 of them are sick enough that they require admission to a hospital bed upstairs. And I consult an admitting service Whether, let's say, if it's a stroke, I'll call neurology. I'll say there's a stroke patient here who needs to go up. If it's an appendicitis, I'll call surgery. Those admissions are generally black and white. If they need to come in, they need to come in. If they've got something that I can fix right away, like they cut their hand doing, because of a broken glass while they were washing dishes, I sew them up and they go home. They'll never need an inpatient bed. So there is a bit of efficiency there. I mean, maybe there's people who are coming into the hospital because they had an asthma attack and they get better quickly, and maybe we put them on a pathway to a bed upstairs, but then they get better. One of the things I didn't talk about is right now the way emergency departments work is, like I just said, I'm going to have 25 patients on my next shift, but there's no physician who's in a kind of a leadership coordinating role. We have started that in Calgary. We call it the Emergency Physician Lead, EPL, and we do have some science and literature supporting this. So that kind of a physician could reevaluate that asthma patient and say, oh, you know what, you're actually getting better. Let me take you off the path to admission. I'll call the respirologist who is admitting you and say, hey, you're doing better, and maybe we can actually get you home. But I don't think this is going to be a common way to reduce the burden of admitted patients who need beds upstairs, or the burden of admitted patients who are occupying precious space, resources, and nursing resources in the emergency department. Is that helpful, Addie?
Yes. Okay. So essentially, it's really more on the logistical side of things that can really contribute to reducing the occupancy.
I mean, if we had a system where, I mean, we'll always have admitted patients in the emergency. We'll never get around that. But if you can not only set a threshold beyond which you should not allow that number or proportion to rise, and create a dashboard that's intelligent enough to say how that should be achieved, that would be very, very helpful. Like if it's to take the two patients that are waiting for an MRI on the 7th floor and send them home and get that done as an outpatient, to allow 2 more people to go upstairs from emergency, that would be brilliant.
Okay, got it. Yeah, because I was just thinking, like, in order to have that type of system, you would really need to coordinate it well between all the different medical centers, the clinics, the imaging centers, in order to really establish that type of data.
It's all inside the hospital pretty much, except for the EMS component and the nursing home component.
Great. Thanks a lot.
Okay.
I think Sean had his hand raised. Sean Murray, did you want to ask your question?
I did, but my question was answered.
Okay, your question was answered. Vaishali, you can go ahead and ask your question. Can you unmute yourself, or?
I can do a Hannah Park's question.
Sorry for the delay.
Okay.
So my question is just like, as you said, the admitted patients are not getting transferred to a rehab center or a nursing home. So I don't know about the system here much. Like, are there not enough nursing homes or rehab centers, or it's just that after they are done with all the diagnosis, they are just waiting for the paperwork and someone to go there and sign and say, now you can go?
Yeah, so it's a great question. And of course, you're talking about the admitted patients that are already upstairs, not the emergency admitted patients, because they don't go straight to rehab. Well, for sure, there's a deficit of nursing home beds, but there's also there's probably some efficiencies to be gained there. Sometimes there are some issues around patient preference and which nursing home they want to go to. I think if we could define more clearly when the process starts, we've just initiated a process here in Calgary where we are trying to take the time where the request for a nursing home bed is put in to the time where the patient actually goes to a nursing home. We're trying to improve that by 50%, which would reduce 4 days and 4 days in hospital could actually make a huge difference and allow not only admitted patients to go upstairs, but allow the EMS to offload their patients. So there's some opportunities there, but my big thing is, like, we can't lock our door in the emergency department. We can never say, sorry, we're full, go somewhere else. Nursing homes stop accepting new patients at a given threshold, which is okay most of the time, but I think there are times when they need to maybe step up and figure out a way to go over by 1 or 2 patients. And there's so many nursing homes around that if everyone had a system for going over capacity, then we would certainly address the part of the problem that's related to nursing home patients spending a lot of time, admitted patients spending a lot of time in hospital waiting for that nursing home or rehab bed to open up. So great question. Thanks, Vaishali.
Yeah, just a follow up with that. Are those patients like good enough at that time to go and wait like somewhere else? Like if there is a change in the infrastructure in the hospital, that they leave the hospital bed, but they just wait somewhere else. I don't know if that's possible.
Well, we've done lots of creative things over the years. So for example, if a patient is going home on Tuesday, but their family's not going to be able to come and get them to the evening, we actually move them into a kind of a family space or a lounge where they're sitting in a chair and, you know, there's snacks, but at least it frees up the bed. So there is some, I don't think you can create places where people can spend 2 nights, but at least the idea of discharge lounges or holding areas where people spend some time so to free up a bed for a patient from emergency while they're waiting for their transfer either back home or to a nursing home.
Okay, thank you so much.
Sure.
Thank you.
I think we had another question from Hannah that you were going to touch upon, Eddie.
Yeah, sure. So, I mean, I just heard this morning, there is a doctor shortage, clearly. And yeah, you can open up the 24/7 clinics, but let me just be really clear about this. The reason we have prolonged wait times is not because of the emergency visits that could have gone to a family doctor. Everybody who comes, nobody wants to be in the emergency department. They almost all have a very good reason for being there. Either they called HealthLink or 811, or their family doctor sent them in, or a family member told them to go in. These kind of minor cases, they're a source of frustration. They're a little bit annoying when we get them, but they're not the cause of the waiting time throughput problem. They clutter up the waiting room a little bit, but it's not as serious a problem as the problem of the EIPs, the emergency inpatients, the admitted patients who are so sick that we know they need a bed upstairs, but they don't have a bed to go to. So sure, let's get more IMGs. Let's get some more 24/7 clinics, but it's a mistake to think that that's going to affect our wait time. It's not. It's going to be a drop in the bucket.
Okay, thank you. So we're approaching the end of our hour here. I think at this point, everyone, please join me in a virtual round of applause for Dr. Eddie Lang and his excellent seminar today.
Thank you so much for having me. Great questions. Thanks for your attention. Sorry about the technical glitches.
Thanks, Eddie. Really appreciate it.
Pleasure, David.
Okay, thanks everyone. And we'll see you at the next MedTech Talent Accelerator Innovation Seminar.